Hi, I'm Paul Fletcher. I'm one of the senior lecturers at the Northampton School of Podiatry, which is where the students learn how to make people's feet better and legs if they get injured. One of the things that I teach is anatomy. So what I'd like you to think about just before this session, maybe your teacher can pause it for a second while you think about this, is why we learn anatomy. What is the point of learning all the names of the bones and structures in the foot? So, the reason we learn anatomy is for lots of reasons. One is for communication, so that we're all calling things the same term. So we talk about movements in very specific ways. We talk about adduction and abduction and dorsiflexion and plantarflexion. And when we write things in the notes, we all understand what they mean. So it's really important that we all use the correct terminology. A lot of the terms are Latin and Greek, so they're quite complicated to know. And it also means that we can actually make a diagnosis. If we know what's actually in an area of the foot, we can maybe decide what's wrong with it. So probably understanding the anatomy and where everything is gives us a really good opportunity to actually know what the problem is. So it's the biggest tool that we have in terms of helping to diagnose a problem. The other reasons we learn anatomy as well is so that we can seem really clever and charge lots of money when we're in private practice. If we call something the big toe, we can only charge so much, but if we call it the hallux, we can usually charge lots more money. It also makes us fun at parties because we've got lots of models and things that we can take for Halloween, and it's also useful in the fact that we know what all the complicated joints are, and when we're doing mechanics and those kind of things. Some of the models that we use are sort of plastic models like this. If you can see, this is a leg. For most people in the street, people think the leg is what we call the lower limb, but the leg actually starts at the knee. That's the anatomical leg that I've got here. There are lots of bones and it's really quite complicated. Lots of joints. You'll be familiar with some of them, like the ankle joint, but some of these smaller joints, maybe like the subtalar joint and the mid-tarsal joint, you've probably never heard of. Obviously the knee joint is an enormous joint. And we can see we've got some models that actually have the muscles and tendons and nerves and things like that in there. The knee's the biggest synovial joint in the body. Synovial joints are full of fluid. Synovial joints typically are designed so that they have a large range of motion. So the knee, the hip, the ankle. In fact, most of the joints in the lower limb are what we call synovial joints. So the knee is quite an amazing structure and an awful lot can go wrong with it. So in terms of knowing the anatomy of the knee and where all the fluid-filled sacs or bursa sit around the knee, that can help us. And you can see there's lots of tendons that make the way around the knee and can maybe get injured. The knee's also got large menisci as well, which are almost like sort of rubber rings, which deepen the knee. If you look at the bones, they're quite flat on top. You can see there are some spikes in between them. These are where the ligaments that hold the knee together inside attach. You've probably heard of the cruciate ligaments. They sit in between the knee. And the knee joint has often been, this is a real set of bones that we've got here. So these were once walking around somewhere. So some of the models that we have are plastic, some of them are actually real. And the knee it's amazing it works at all. Somebody once described it to me as being two marbles on a tabletop, and actually the way that we actually, all our weight goes through that and manage to support us is incredible. And the knee actually sort of locks in position during stance, so that we can stand up, and that mechanism is quite complicated really. So these are all things that we're likely to learn in anatomy on the podiatry program. We have some very detailed models as well. This is a model of the foot, and we can see that there are different colours. We've actually got yellow nerves. In real life, they're not actually this colour. They all look sort of brown, and I'm kind of lucky that I get to take the students to do dissection at the medical school, where they actually get a real lower limb, and the students will do their own dissection of it. And things aren't colour coded like this, so the students need to know what they look like in real life really. But what we're going to be looking at is maybe some of the students examining nerve function shortly. In one of my previous talks, we looked at the vascular structures and how we can assess those, because we need to know about blood flow into a foot. There's lots of ligaments as well. The ligaments and tendons tend to look white on these models. And you can see there's a whole lot of things going around the ankle that the students will be expected to know. One of the sessions I did with the students a few days ago is we drew from scratch on the board all the things that go around the ankle, and this is what the students would be expected to learn. We put all the veins and the tendons all in and around the bones, and that's a typical kind of exercise that we do in class in terms of learning anatomy. So yeah, I've got two of my third year students here who are just testing reflexes. There's quite a lot of physical assessment that's involved in terms of assessing a patient, and this is last time we had a look, we were doing some vascular assessments. This is quite a simple test which actually tells us a little bit about nerve conduction. Tells us whether the nerve leaves the spine and comes out to the legs and goes back safely. It also tells us a little bit about muscle function, that the muscles are working. I don't know if you want to do it again. This is a normal knee jerk, which is a monosynaptic reflex arc. Maybe you could look that up. There are lots of diagrams in books and things. But the students need to know that the nerves are working adequately really. So this is a basic test that students will do on patients, and they practice quite a lot on themselves so that they know what normal is like. Once students know the anatomy quite well, we can do things like scanning. This is an imaging system. This is an ultrasound scan. We're using coupling jelly, which actually means that the ultrasound waves can pass into the body without any impedance. And we're actually getting this image coming up on the screen here. There's quite a few things that we can see in there, and what we get is we get a cross section. So if you imagine the ultrasound beam is going down and through, it's almost what we're looking at is if we were to cut the ankle open and open it out like that, and we can see inside. So I'm going to point out to you some of the things that you can see on the scan here. So we've just turned the lights out so that you can see a little bit better. Hopefully you can see my little cursor here. This is bone. So this white line here that you can see, this is actually bone. And to be absolutely sure what you're looking at, you need to be imagine where you are on the foot as well. So it's something that we do in real time. And I think you'd agree that looking at this image, it probably looks like a map of the moon if you didn't know what everything was. So if I point out what everything is, this is the skin right at the top. This is where the probe's actually contacting, and we can see this is the integument or the dermis, and the skin over the top. This area down here, this is just the subcutaneous fat that sits there. And here we've got this white line that's running across. This is known as the deep fascia. And here it's really thick. It's actually called the retinacular, from the word retain. It actually holds down all the structures at the back of the ankle. And they're in a nice tight channel in there as well. So all the important stuff is underneath this white line. So all the tendons and vessels and things like that are sitting under here. So what we can see, I don't know if you want to just move the probe a little bit distal. So we're moving away from the leg into the foot a little bit more. We can see a nice interesting thing just up here. This is a superficial vein. This is actually on the outside of the retinacular. So this is one of the superficial veins. You may be able to see this through the skin because it's on the outside of the retinacular. We know it's a vein as you press on it. We're pressing on the probe, it squashes it, and when you release it, because it's low pressure, it releases. Underneath the retinacular, we've got the main vessels. Vessels tend to look black like this because they are mainly fluid inside them. It's the air that sends back the lighter colours, the air in the tissues. So we've got some vessels here. So if you want to move a little bit more distal as well, so just coming down, I'm just going to, perfect, there we go. Just as I was panicking that we wouldn't find it. These are a mixture of veins and arteries. And I don't know if you can wiggle the probe just this way and that. So we just had a perfect picture and I've moved it. Can you just hold it there for me? That's lovely. A little bit of pressure off. This white bit here, this is the nerve that you can see here. So we were testing the nerves and seeing them actually function earlier, but we can actually see the nerve here. And if we were going to put some local anaesthetic in, we want to put it in around this nerve bundle here, which is really close to the artery. I'm just going to, if you can just press on the, that's lovely. So this is the artery that's left here now. All the veins have been crushed. So if you kept, there's not a massive amount of pressure. What do you think, Rachel? It's not a lot of pressure, is it?
No, I can still feel all my foot and everything.
So that's enough pressure to actually collapse the veins. So if we left this probe pressed on here for another 20 minutes, we'd probably end up with a deep vein thrombosis in this limb. So we won't do that, obviously, because that won't be good. But now the veins have all sprung back to life again, the blood's flowing in there. I'm just going to turn on the colour Doppler, which is going to give us a nice colour image now. So what we can see there is we can actually see the blood flowing in the artery. We had a nice picture. We just want to point it in the direction of blood flow a little bit, so if we can. Ooh. Sorry, that's me interfering. I've actually got a worse image now than we had before.
So it's normally really good pulse then.
Yeah. So there we are. I don't know if you can hold that and I'll do the on-screen movement. So here we can see the blood actually flowing into the foot. There's very little sort of blue flow at the moment. That's because the veins aren't working. But what I'm going to do is I'm actually just going to squeeze the foot and augment the venous return. And you can see it light up there. Not the clearest image we've ever had of a vessel, but and the veins are very much under the influence of the pressure of the muscles squeezing against them. We've got quite a lot of other structures. I'm just going to take the colour Doppler off, as much as beautiful as it looks. Just so that we can have a look a little bit at some other structures. We've got a lot of tendons in this in this area as well. I'm just going to try and find a nice one for you to have a look at. Tendons change as you move the angle of the probe. So I don't know if you want to be about there. Yeah, I think we're just running out of jelly. This is what happens when there isn't enough coupling jelly. Basically, if you get air between the foot, and they are funny shapes, feet, so you need to get a good contact without any air between. So what I want you to do is move the probe this way and that, so that you're going to go that way and then this way, yeah? Okay. Beautiful. So you can just hold it, just hold it there. Yep. Can you just keep it there? Yep. That's brilliant. So these are tendons that you can see here. Let me use the cursor again. So these are tendons that are running here. They show a thing called anisotropy, so they get lighter and darker as you wiggle the probe backwards and forwards. So if you wiggle it backwards, see how they've gone dark and now they've gone lighter, and then go back the other way. I know you moved a little, but that's good. So you can see there's actually a little ring of fluid around. This is actually, there you can see perfectly a little ring of fluid. This is actually what we call the synovial sheath that allows that tendon to slide backwards and forwards. So we can actually find on the image where there maybe is damage to structures, nerves, and things like that. So that's pretty good. You see the bone was just showing up quite nicely there. Here we can see the retinacular. So it is a useful piece of kit for visualizing the structures where they're deep in the skin and you can't normally see them. So I don't know if you just want to put the lights back on again. So we've looked at some of the things that we could use for anatomy. We use it for scanning. We use it to communicate. We use it to know where structures are and help us with diagnosis. And we also use it for working out if there's a problem anywhere. Now all the sensation under the bottom, what we call the plantar surface of the foot, is actually provided by the nerve that comes round this side of the ankle. This is called the tibial nerve, and it's actually coming round a bit of a corner around here like this. And it's actually dividing into 3 branches as it comes round this side. So we've got a branch that does the back of the heel, a branch that does this outside bit of the foot, and a branch that does all underneath. So this is the area where we naturally want to put a needle in, and just yesterday I was injecting a patient to make the bottom of the foot go numb so that we could cut something out. So if we didn't know the anatomy and where the nerves ran, we wouldn't be able to figure out where to put the needle. So this is why another good reason why we learn anatomy. So we've talked a little bit about some of the imaging that we can do in real time using the scanner, but we have these boxes that are on the wall here. They may well be in a museum soon because we use a lot of digital imaging. But what do you think we probably use this box for? Maybe you want to have a think about that. Well, we actually have these. These are non-digital images of feet. I've actually got it on backwards way around. So these are typical of the kind of images that we may request. And obviously we'll be looking at the bones, and this is essentially this is what's called an X-ray, but it depends on, it's basically a shadow graph. We pass X-rays which will pass through the soft tissue and get reflected by the bone. And depending on how much X-ray gets through, you get these images really. You can see the image of the foot if you look quite closely in the soft tissue, and there's quite a few interesting things to see. This is what we call an anterior plantar view, or an AP view. And this is a lateral oblique view of the foot. We can see different things, and we normally need 2 images so that because it's just a shadow, we might miss something on one of the images. On this side as well, if you can just see here, you may think that these little lines here are fractures at the ends of the bones, but maybe if you want to pause and maybe have a discussion of what you think these might be. In actual fact, these little changes, these are what are known as growth plates, so we know that this is a young child that's been x-rayed, because these little bits, these close up on an adult x-ray. We've looked at these images, we're quite happy that these look relatively normal. If anything, there may be just a very slight flattening of the metatarsal head on this one, given an unusual joint space, but not an awful lot. But this can be helpful in terms of maybe determining if there's something wrong, if somebody's got a pain in the foot. We're very careful about when we do x-rays. We have these lead aprons which are just next to us here, and the lead aprons prevent x-rays getting into the body. They are quite dangerous, so we only use these pictures in very special circumstances where we want a definite answer to a problem that we might be faced with in clinic. So I'm the admissions tutor for podiatry. I'm a senior lecturer. I take the students to do the dissection at the medical school, and I teach them the medicine and some of the clinical skills practically. Before I was a lecturer, I'm a full-time lecturer now. I used to work in limb salvage, working with people who had really serious medical problems, working with teams who, with specialists and surgeons who were going to try and save people's legs, and I was the podiatrist in the team. I got into it because I was interested in general medicine, and a careers advisor was good enough to just point me in the right direction and suggest podiatry. And the thing I like about podiatry is it's really practical. You get to do lots of hands-on things. You get to spend a lot of time with the patients. You don't need to be doing a lot of shift patterns. You're working in normal time because you're a specialist, and it's really quite enjoyable. So in order to be a podiatrist, you need to get a BSc honours in podiatry, and it's the only way that you can actually call yourself a podiatrist. Once you're qualified, you do need to do continual professional development. So you constantly have to be studying, and this is monitored by the Health Professions Council to make sure that you're keeping up to date with practice and current clinical changes. So whilst you don't have to sit the exam again, you do have to make sure your knowledge is maintaining to be current, really. And it's a tough qualification. I think it's quite difficult to have to do to get through. It's probably a lot more difficult than some non-clinical courses that are available. I really decided on podiatry because there was a shortage of podiatrists. I qualified in the mid-80s when they were desperate for podiatrists, and there were lots of opportunities for jobs. And this is exactly the same as it is now. There's a real shortage of podiatrists in the UK. I think it's one of those things that maybe people don't think of when they're considering medical careers. They just think maybe about just doctors and nurses and midwives. And it is one of those areas that is a little bit off the radar. The beauty of treating the lower limb as well is that you don't have to do some of those horrible investigations that maybe other medical people have to do, which I'm quite glad about. I'll not go into detail, but maybe you can suggest some of those to your teacher. I think I'm talking really with my podiatry head on. So I've actually been a clinician for a long time, actually working with patients. And the best bit about that job is actually fixing somebody, seeing somebody come in and not being able to walk, and then being able to feel much more comfortable and being able to get back to the normal sports and routines. It's really rewarding. It's one of the few medical careers where you can actually fix something and the patient feels better straight away. Most things in medicine, you've got to wait several months until the tablets work, and even then you might not be around when that happens. So it's kind of nice that you can do something and the patient feels better straight away. So I really like that. Slightly different now being a lecturer. It's really rewarding to teach students how to do things and go out into the world. And then I get lots of messages from students who've seen things that I've taught them and they've made them better, and it's really rewarding to find that maybe students have actually saved somebody's life because of the knowledge that they've been given. I think the most challenging aspects of the job are the fact that people don't always know what podiatrists do. I think it's one of those professions that is a little bit under the radar. People maybe are under the misconception that you just cut toenails, or people think that it's sort of horrible dealing with feet, when in actual fact there are a lot of worse parts of the body that you could be dealing with. I think often we do just have to educate people exactly what the scope of practice is and what we're doing, so that can be a challenge at times. The other things are not everything gets better. I mean, to go back to the good things, you're not dealing with death on a daily basis, so we very rarely have to be informing people that people have died, and very rarely things end in fatality. But occasionally things don't always go to plan, and you can have things that don't get better, and that can be a bit challenging at times. One of the great things about being a podiatrist is you do work sort of 9 to 5. You work sociable hours. You don't have to do late night on-call shifts. We don't really do emergency work. We are specialists in the area of the lower limb, so people will send patients to us to be assessed and treated within normal hours. And if you've got an NHS post, it really is 9 to 5, Monday to Friday. So if you do want to do private work, you can do that outside the hours of normal practice. A lot of people have Saturday morning clinics if they work in the NHS, and maybe an evening clinic where you see your private patients. And you can mix NHS work with private work, so you could have your own business and do locum work within the NHS, or you could work for a sports club treating sports injuries as on the side of actually working full-time in the NHS. So it's really quite adaptable in terms of a career path. So a normal shift pattern for a podiatrist varies greatly, and it depends on your job role. From my point of view, when I started in the NHS, I'd be doing something quite different each day of the week. So I'd probably have a day where I was actually doing, I used to have a day where I just did the surgical blocks, the nerve blocks, prior to surgery for the surgeons. I'd have a day where I'd be in hospital treating the complex cases with the multidisciplinary team. Sometimes you have to visit patients at home that aren't mobile, so I'd have a day where I'd go out and actually visit people in their own homes and organise the treatment plans. I'd have a day where I might be working in the lab making orthotics and doing musculoskeletal injuries. So it does vary from day to day what you're going to be doing. You're very rarely just doing the same thing every day. Now as a tutor, Some days I'll be doing marking. At the moment I've got a big marking schedule, so I'm doing lots and lots of medicine papers which I'm marking at the moment. I'll have lectures some days, and I'm lucky that I get to come in here in the clinical unit and actually treat some of the physical problems that people have. So I'm not just a lecturer, I do still have some hands-on and practical experience, and I think, you know, if I was just a pure lecturer I probably wouldn't want to do it. It's the practical stuff that's important to me. The progression routes for podiatry, there's lots of different specialisms that you can go into when you're a podiatrist. One thing that you could do is go on and become a podiatric surgeon, where you're an AHP specialist, and obviously you get a lot more money for doing that. I'll let you look up how much a podiatric surgeon earns online, I think. But that's where you actually go on and do bone surgery and pinning toes and some of the more complicated things. As an undergraduate podiatrist, you'll be actually doing minor surgeries, nail surgeries, minor skin surgeries and some injections and things, but you can go on and do the more complicated stuff. You can also progress into musculoskeletal sports injuries and maybe become a specialist in sports injuries. Or you can go on and do the kind of work that I did with maybe limb salvage, where you're working with a lot of diabetic complications and maybe general health complications within a large hospital team as well. So there's quite a lot of progression for podiatrists, and some people do go on to become hospital part of the management team as well. I think the advice I'd give to somebody who's thinking of coming into podiatry would be to actually do a bit of research and actually find out a bit about the job. I know I've talked a little bit about it today. We also want people to get some work experience and actually spend some time with a podiatrist and make sure that it's the right career for them, because it isn't for everybody. You need to be quite a special person to be able to do some of these things. So I'd recommend that you go out, get some experience, find out, do a bit of research. The other thing as well is, you know, I think empathy is quite a good skill. Imagining what it's like to be quite frightened. Patients do get upset because they're in a lot of pain, and maybe just taking the time to think, what would it be like if I was in a lot of pain and couldn't get my foot fixed? How would I feel? And obviously when people are in pain, they can be difficult to manage. And I think as well, just keep things fun. It is an awful lot of fun, and if you can make people feel comfortable and settled, it's a really good quality that you can have. Maybe even you know, like a swan, your feet are paddling underneath the surface, but you need to be able to keep sort of light-hearted and make everybody feel relaxed around you. That's the kind of quality that I'd expect in a podiatrist.